Morning, everybody. Welcome to Oldham Primary Care Commissioning Committee. I thought it might be quite useful if we did a bit of a round of introductions. This is our first meeting in the very new membership format. So we have some people joining us today for the first time. Some people have been here many, many times over the past 5 years or so. I was probably suggesting since I've been around. Let's just start with yourself, Debs, if that's okay.
Hi, my name's Deb Waterhouse, Deputy Team Leader. I'm here just to support the meeting, doing the minutes.
Brilliant, thank you. Simon.
Morning all, Simon Walsh, Primary Care Quality Manager.
Carol.
Good morning, everyone. I'm Carol Gibson. I'm the Senior Finance Business Partner for Oldham, covering primary care and prescribing.
Marion.
Good morning, Marion Colohan, Assistant Director of Communities and Partnerships.
Tarek.
Tarek Shelf, Head of Primary Care Operation for the locality ICB.
Dr. Lewis.
Hi, thank you. Brian Lewis. I'm going to just come up with various roles so it automatically fills all the declarations of interest at the same time. So I'm actually here on behalf of the Oldham GP Board as Chair of the Oldham GP Board. I'm Clinical Director for Oldham Central PCN. I'm a GP trainer at St Mary's Medical Centre, Chair of GTD Healthcare, and also lead the Oldham Trainers Group. And I occasionally have a day job as well. Thank you.
Brilliant. Dr. Vance.
Oh, good morning, everybody. I'm here representing the LMC for all of Oldham today, although I do have two surgeries, one in North and one in Central.
Thank you. Gail.
Hi, good morning, everyone. Gail Lett, Head of Primary Care Assurance for the Oldham locality.
Charlotte.
Hi, Charlotte Stevenson, Consultant in Public Health at Oldham Council.
Dr. Patterson.
John's not here today, is he?
Yeah,
no,
yes.
Yes. Hi, everyone. The confusion being that I sent my apologies because I'm at an elective care conference this morning, but the first speaker hasn't turned up. So it's my great pleasure to join you this morning. I am the Associate Medical Director for Oldham and part of ICPGM, and I'm a local GP in Oldham. Thank you.
Nick.
Morning, I'm Nick Addy. I sit on the GME's local optical committee and I'm in optometric practice in Oldham.
Brilliant, thank you. And finally, Erin.
Hi, Erin Portsmouth, Associate Director of Strategy for the Oldham locality. Apologies, I have no Wi-Fi where I am, so my camera will be off.
No problem, thank you. Okay, let's shift us onto the agenda proper then. So, Debs, can you confirm apologies for us, please?
Yeah, we've just got Nicola Hepburn, Director of Delivery and Transformation for Oldham, who's a voting member, and that's it.
Okay. And in terms of declarations of interest, is everybody comfortable that the doctors on the call have suitably and appropriately described their involvement in various different parts of our system? We don't need to go back over it. Seeing lots of nods for that, so we'll take that as a yes. I'm going to shift the action log to the end of the meeting today, if that's all right. Mainly because one or two things are in my name, and obviously I've been in hospital, so some of them aren't completed. So rather than type the meeting with that, we'll deal with it at the end. And I was on leave for the last meeting, so those that were here, are we comfortable to sign the minutes off as a true and accurate record of the last meeting at the during August? Brilliant, thank you. So I'm also saying no to that. Right, so that takes us then to the first item proper, which I believe is yourself, Tarek, on general practice training and half-day closing.
It says, yeah, thank you, Mike. Apologies if I look off to this side while I'm speaking. My printer's broken, so I'll be able to print it out. Yeah, so this is basically an update on where we are with our half-day closure policy for the locality. The report just provides some background where we currently are and also some options for the continuation of the policy or otherwise as the committee sees fit. So the background is that in 2019, the senior management team, what was the CCG, and CCC ratified the half-day closure policy. It was quite closely aligned to what was the old Primary Care Plus scheme, which provided for half a day closing per month to support education and training for practices, although I think it's fair to say that the locality supported half-day closures for education and training for quite some time prior to that policy review and updates. There were some conditions around it when the way it was originally envisaged, which was that practices were only allowed to close for 1 half day per month, and that they had to either effectively use it or lose it. So if they didn't use it, they couldn't carry that forward. It would have to be a agreed date each month that the practice could close. The locality would fund clinical cover, which I think for some time has been provided by GTD Healthcare, who've been a very responsive provider for providing that. And then the sessions would be split equally between which kind of pre-primary care network, but the locality and the ICB, and it would rotate. So 1 month it would be practice, the following month network, and then the following month an all practice education event arranged by the locality. In theory, practice could close from 12 noon to 6:30. I think in practice, a lot of them close a little bit later than that, usually after 1 o'clock, to allow for the completion of the work in that morning. And that was really where it was with it. If they wanted to change a date or do something, they would have to provide us with some notice. So that was probably implemented in accordance with the policy up until COVID. I think it's fair to say the pandemic changed things slightly. We were a bit more flexible. Some of the funding arrangements were also changed. So the locality has been funding all of the half-day closures, not just those for either the practices or the ICB as it is now. So that's kind of where we were in terms of the implementation of the policy. The report just provides a little bit of information of what we tried to do as a locality, and particularly since coming out of the pandemic. I think we've had some really good educational sessions that have covered specific clinical areas. I think it's fair to say that those are relatively well attended. It's not 100% attendance with every single clinician. It's not mandated, but obviously we do like to see as many people there as possible for the ones that we've put on. We don't police it in the sense that we're not asking practices or network to report on every single individual and what they're doing in those afternoons. The policy is on a high level of trust. So our assumption and expectation is that there is something in place for most staff within practices on those half-day closings, and I think it's fair to say that practices do use them in different ways, but usually for the benefit of education and training. So that's where we are in terms of the utilisation. From a background perspective and some context, is our understanding is that this will and is starting to be looked at across GM, obviously now being part of the ICB. And within the report as well, hopefully you'll have seen that every locality has a slightly different arrangement. I think ours is one of the more accommodating arrangements, looking at other localities. I think we are a little bit of an outlier in the sense that we tend to fund as many PCN sessions as we do at the moment as well. But I think obviously the background and the caveat around any recommendation that PCC would reach today is the fact that that may be superseded by a Greater Manchester decision on what the expectation is to align localities. In terms of a cost perspective, we cover it out of our primary care training budget. The cost has increased quite a bit, but because we've been using additional days, so we've actually tightened that up in the second half of this financial year, and we've reinvested that money that we're saving back into primary care training. So there's actually some admin training next week that we've paid for. That was one of the agreements we reached with the practices who were quite happy to change that as well. So in terms of options, there are a number of different options, and it would have got quite complicated to go through all the different possibilities, but essentially, just to narrow it down to around 4, we can continue to fund 1 session per month in accordance with the current provision up to and including March 2024, but with the understanding that we will review how this is used, and it has been used this year, to inform any decision. We can allow practices to continue to close for half a day per month in line with the current arrangements, but the ICB would only fund the sessions that we arrange quarterly. We can allow the practice to close for half a day per month, but just fund the ICB and the practice sessions, And we could still allow them to close for the PCN days, but the expectation would be that the PCNs would need to pick up the cost for the clinical cover on those days. Or we can discontinue the closure policy completely from January onwards, obviously understanding that actually some practices, PCNs, will have already booked things in for the final quarter of the financial year and remove the provision for half-day closing completely. Or if PCC wishes, then they may want to consider a hybrid of one of the options that are available.
Okay, thank you, Tarek. And what happened then? Sticky buttons. Have we got any questions for Tarek? We have 3 options on the table, I think. Marion.
Some questions and comments from me, Chair, if that's okay.
Yeah.
Firstly, Tarek, thanks for the paper, and more broadly, thank you for all the hard work that you do in arranging the education and training sessions. I think it's safe to say that the last 2 around women's health and menopause have evaluated really strongly with clinicians in Oldham, and I'm really happy that Oldham CCG as was, and now the Oldham locality, has always had such a strong focus on providing protected time for education and training, and has funded these sessions and these half-day closures. I think what is clear is that there is going to be a Greater Manchester review. As with everything now, as we've moved into GMICB. I think, as you pointed out, it is clear that we have been very generous with our application of the policy in Oldham. And while I'm pleased that we've had this high trust system, and I wouldn't want to lose that moving forward, and we certainly don't want to create an industry for either ourselves or, more importantly, practices out of half-day closing. I did note from the paper that there are some practices who don't attend the training sessions or send low numbers of staff, when we're holding the central ones. And I think in those instances, we are going to need further assurance, so we can provide assurance to Greater Manchester ICB about how practices are using those sessions, because the reality for all of us is that any spend is coming under great scrutiny now. So I think we are going to have a few more conversations with how these sessions are being used, and really to try and encourage attendance at the CCG sessions. I think for PCNs, they could probably provide a plan in advance of how they intend to use the PCN ones. And all of that is caveated with, I would support continuing locally, but there may be a GM review that trumps any decision we make locally.
Okay, thanks, Marion. John?
Thank you.
Thank you, Tarek, and thank you, Chair. This is some of the best money that we spend, I think, getting us all together. It paid us dividends in COVID when we had that, because we had that habit of getting together, and we managed to land our digital platform and our video platform just before COVID hit, and everybody was in the room together. It was the last time, wasn't it? What seems like a long time. And then since then, we are better together, and that community of the practices coming together is important, and there's a lot of soft stuff that happens around those meetings that are important. And certainly when we think about the ambitions of the PCNs, the ambitions of us as a GP family, being able to get everybody together in protected times. So the 2 things that I want to just note is, number 1, this is paid for out of at the moment it's paid for out of the local incentive scheme. So the GPs together have agreed that instead of that extra money falling into the practices, it goes towards the central scheme. So those practices who aren't turning up are actually shortchanging themselves, because they have decided to, fund this education program rather than get it to spend on their own resource. So they should be there. And I think there's a bit of work we can do on that. I do think when I go around other localities, we have a really high attendance in terms of coverage of practices and actually diversity of staff. So that does serve us well. I don't think we would have done the quality improvements or achieved our CQC overall picture without these sessions. So that's the first thing, is that this money at the moment, and so just to confirm, Tarek, about going forward, that the budget for this next year would be from that quality scheme budget, because I think GPs would be happy to do that we can go out and ask them again, but we have the feedback from the sessions, Marion, and we have had the previous discussions we've done. And, you know, I'm sure Brian could bring it through board and give us a board view of this spend from the equality scheme. Apologies, because obviously I'm in a machine in the background. And then the second thing is, this half-day closing a month doesn't affect our access. So yes, we do have a couple of practices who have been highlighted in the local press about their access, but half a day once a month does not reduce our access significantly. And of course, a lot of other PCN averages and practices attend this half-day practice and achieve the 75 patients per thousand or 75 appointments per thousand. So I just don't think this is an access issue. And in fact, I would argue that this protected training time retains our staff, but also allows us to introduce the diversity of frontline staff and, you know, the various colleagues that we bring to the front line of primary care, which helps our access. So those are my 2 points, really, Chair. Thank you.
Yeah, thank you, John. Andrew.
Thank you. Yes. One of the things that I'd just like to reiterate what the others have said already, it's a very valuable resource for primary care. I'm just thinking from an LMC point of view that we've had a very high number of surgery closures, and this half-day closing is an opportunity where surgeries can get together and train people and ensure that we're stepping up to that. So whilst I know the CCG funds the primary once every 3 months, but the other two local ones are extremely useful for primary care to try and just look at things and make things are safe and secure for our patients. So yes, it doesn't impact upon the access, but it does help make sure the surgeries that are making the most of these opportunities are safe and secure moving forward. So it's been from a GP point of view, it's been a very positive thing that we've had this regular time and the support from everybody.
Thank you, Andrew. Brian?
I just want to agree with everything that I've heard so far. As a GP educationalist, I think it's absolutely vital that we carry on with the sessions. Certainly, if I use my own examples from Oldham Central for the PCN, we've been having regularly quarterly sessions, which have been absolutely vital, where we've had an amazing attendance, to be honest, where we've had 180 people attend at each one. And the evaluation has been really superb. So I do think we should be continuing. I think, if anything, I'd value more expansion, because education is just so important all around. And if we're covering the whole workforce, not just the GPs, but the nurses, etc., we do need to keep on attracting people into the area as well. And I think the scheme actually does help practices with their recruitment. Thank you.
Okay, thanks, Brian. So, summing all of that up, there is absolutely no desire to discontinue the scheme, Tariq. Surprise, surprise, I don't think any of us would support a discontinuation of the scheme. However, there are some kind of pretty important things, aren't there, really? So we have to be mindful that we are one of 10 committees that sit underneath the Greater Manchester Committee, and the desire of Greater Manchester is to review the whole thing, presumably to either level up or get some consistency across the whole of Greater Manchester, depending on which way you want to look at it. So whatever we do is going to have to be in the context of there is going to be a review across Greater Manchester. I think from this committee, we ought to be trying to influence that review as much as we can, because the paper also clearly demonstrates that we have one of the better attended schemes and one of the most enhanced schemes out of all of that. We shouldn't be aspiring to reduce our thing across Greater Manchester. We should be trying to influence Greater Manchester for everybody else to be our position around all of this. So I think that needs to be an action for John and I to take away outside of here. Marion's point is pretty important. Whatever happens, it's also pretty clear we're going to come under a kind of greater level of accountability for these things. So we're going to have to think about, how do we police a scheme without it looking like it's Big Brother watching GPs? Because that's not what we want. But equally, we're going to have to provide some assurance, and we have to be realistic about all of that as well going forward. So there's some practical things that we need to do and work with local GPs as a consequence to it. And then in terms of the residual 3 options, which are the main show, the proposal is either option 1 or option 3, I think, as I read the paper. Does anybody have a particular preference for either of those options? It seems to me option 1's the continuity option. And if people are happy with just staying with the status quo, it's no change. We don't have to communicate a great deal of change. it doesn't water anything down. Option 3 is doesn't massively change things, but it requires a whole load of communication to people that will then probably set the hairs running unnecessarily. So if people are comfortable with option 1, I'd suggest that's the one we go for, and then we pick up on the other points as part of the actions as a consequence. Are people comfortable with that? Fabulous. Lots of nods. I'm going to move us on then. So general practice quality scheme, which I think is you, Simon.
Thank you. So just an update on CQC publications over the last couple of months. Moving on to an update for the assurances around the Doru practice, which received an inadequate rating, and just an overview of the GP patient survey and the work going towards some of that. So starting with Worneth Medical Practice, they were published on the 30th of August, received an overall rating of good. However, they did receive a requires improvement rating for effectiveness, which was based around the childhood IMS and cervical screening uptake. The practice spoke to Dr. Butt last week to see if he'd had an update. He has asked for a review of that rating for requires improvement, based around the demographics and a couple of other things. He's not heard back from the CQC yet, so it remains in place for now. Littletown. So Littletown Family Medical Practice, they had their report published on the 14th of September, received a good overall, with some outstanding areas, which were they held an educational event at the local mosque, with a lot of the clinicians speaking both Urdu and English, a lot of attendees, massive impact on the community, very positive on that. The nurse also holds a weekly walking group, mainly to promote the exercise, but also for a lot of informal discussions, which has uncovered a lot of patients that require additional support, which otherwise wouldn't have come forward. So again, very positive, seen as an outstanding area from CQC. And the other outstanding area from Littletown was they were commended for the prostate cancer screening programme. And again, a lot of early diagnosis coming from there. So very positive around Littletown. No other CQC reports currently being published. There's a couple of reports we're waiting for, but not republished yet. We held a primary care performance management forum at Doru. So Doru did receive an inadequate report from CQC, I think in June, July. There's been a lot of support around them to try and improve that, to try and enhance their service. We held the performance management panel just to ensure that the safety of the patients is still going on, and from that we're still waiting for some reports coming back from the CQC and professional standards. So from there, primary care team have asked that we will be carrying on with some audits to make sure that the safety is critical, that the safety is there for the patients, but up to the other reports have been published, we can't really say much more than that. General practice patient survey, there was 5 practices that were rated quite low across Oldham. There were, I think, 19,000, just short of 20,000 questionnaires sent out, but only 4,000 returned. It's quite a low response rate. It's quite a disappointing response rate. One of the practices, I think, received a 9% completion rate. There was nearly 900 surveys sent out with only 82 returned. It's one of the things to consider, I think, when looking at the patient survey, and one of the things that we've been out and spoke to all the practices. It's one of the things that I think the practices need to work on to get that response rate built and to improve that. All the practices have carried out their own surveys to show that it's not a true reflection. However, the patient survey is the one that's out in the public domain. It's the one that's there that's seen. Excuse me. So yeah, spoken to all the practices, their own surveys have been carried out. There's a lot of work going on to improve the responses for this. There's a lot of work going on behind the scenes, data collection, all sorts of things to try and show that this isn't the true reflection. And we're working with the practices currently. We're going to collect a lot of the data from what they're doing and then report back to yourselves, and possibly next time, just to show that this is there is a big improvement across that for the patient survey. And I think that's pretty much it for the quality paper. Any questions?
Okay, I'm going to try and kind of steer this in a sort of narrower space, I think. So, great news about Little Town. Really, really great news. Some outstanding practice in there. Never read about the other practices of areas of really good delivery. We should be commending them, and I think we should probably send some notes to them to say that we're grateful for their hard work. I just want to concentrate on a few areas in this report, though. So I don't want to get into a heavy-handed conversation about Duru in this particular space, but I think we do need some assurances that we are doing all that we can to make sure that we follow through on our contractual obligations and not just leaving it to the regulators. So I'll come back to that in a minute, Marion, if that's okay. And then the practice survey stuff, I just think we have to be really mindful here. As painful as it is to read some of it, that's what people feel. And they're entitled to feel that way. If that's what they feel, that's what they feel. And I don't sat on looking at that list of practices and seeing it as I saw it when it first came out, there's absolutely no surprises to me about the names of those practices. So whilst we may well be doing great things, or those practices may be doing some great things, clearly there are some people that feel pretty aggrieved by the level of service that they're currently getting. And we need some proper work to make sure that there is an improvement plan in place. So for me, if I flick to Marion, there's something about the Duru stuff that we need some assurances in here in this part of the meeting. And then there's something about an expansion of what are we really doing to bring about improvements in primary care access in those, or primary care experience, I should say, in those 5 practices. Thank you.
Okay, thank you, Chair. In respect of the Duru practice, we are following the meetings and the conversations that we've had with them. We are continuing to engage very closely with the practice to ensure that we have assurance around the standards of care being delivered there. In respect of the contractual processes, because of course we are talking about different lines of inquiry here, the CQC being the independent regulator, professional standards, looking at Dr. Duru's individual practice, and then ourselves as GM Integrated Care under delegated authority from NHS England to ensure quality and safety in respect to the primary care medical services core contract. We are following all contractual processes in respect to the Duru practice, and all appropriate notices have been issued. However, Dr. Duru does have the right of reply to those notices, and as such, I will need to come back to the committee with a further update. But I do assure the committee that we are working through all those processes in parallel.
Okay, so we're not doing nothing, and we're going to have to come back with a next stage report following the performance report procedures. Thank you.
Thank you, Chair. Could I also just comment on some of the other areas, if that's okay? I know Dr. Vance is waiting to come in. In respect of Werneth Medical Practice, this was a very solid, good report, and the areas there requires improvement in one area, and that was predominantly because of childhood vaccine immunisations uptake rates. And Gail, could we, as we look at the strategic piece of work that we're doing around MMR, because this is a practice who does have quite a challenging population registered with them in respect of vaccinims, where there is perhaps a lot of education needed doing and a lot of community engagement needed to get those families in. Gail, I think, could we link Werneth Medical Practice in with that piece of work and perhaps approach them as being a test site as we move that piece of work forward, because I think it would really benefit them and it would really benefit the local community. Matt, you've already reflected on Little Town, but you know, Dr. Paveen, with her work around prevention and community engagement and population health management, you know, that she initiates herself, and her outreach into the local communities just continues to go from strength to strength. And I think, you know, access to general practice is, you know, is so important for our residents in Oldham. It continues to be a topic that is on everybody's list. I think what I would say about the 5 practices that were highlighted here, they have all engaged very well with the team. we have been out to visit them all. They have got action plans in place, and I do believe that they are committed in trying to improve this, the outcomes of the recent survey. And I think, you know, for all of them, there's a lot more to be done around, you know, developing community engagement and relationships, be that through a PPG or through other areas. All for me. Thank you, Chair.
Andrew.
Yeah, thank you, Mike. One of the things I just want to reflect on was what you said at the start. This is what people are thinking, and it is what they're thinking. I agree, it's what they're thinking, but I just want to sort of reflect on the impact it has upon primary care, about primary care individuals. We're at a time where we're trying to recruit and maintain employees and staff and doctors, and there's a huge amount of staff turnover, more than there was historically. And I think, just to give you an example of the perception, is that things are not available and there's a lot of dissatisfaction. But I had a letter flagged up to us that was via a local MP, and the patient had written to the MP saying that she could not get an appointment within the NHS. And I looked at that person's notes, we looked at it, and it turns out that this lady had 13 appointments in 12 weeks. And her impression was that she was not getting enough care, but she was having 13 and 20. That's more than one a week, you know, and that is not sustainable in primary care, and actually was impacting upon other patients' ability to achieve care. Her perception was that she wasn't getting it, but actually, whenever we sat down and looked at it, it was very, very different. And I think that perception needs to be changed, where somebody can get more than one appointment a week and write complaining to their MP saying, I'm not getting the care I want. So I suppose any help that we can get as an Oldham wide to try and address the perception as well as the actuality. There will be areas where I'm sure we can improve, and that is brilliant. But I think there's a massive perception here. And yes, they do think they're not getting stuff. But the reality is, when you look at it, very often, those self-same patients are getting a lot more than the average person is getting. And there's a great degree of anger since the times of COVID in the community. People are angry with a lot of things. And so I think I'm just saying, yes, the perception is definitely that. I'm not always convinced that it's justifiable anger, and it's going to have an impact upon our workforce if we don't find a solution to try and help address this.
Recognise all of that, Andrew, and I suppose my comments were much more about we could spend all day arguing about a low turnout and a low percentage. It's that just diminishes someone's experience, and I think we need to not lose sight of it's a real experience felt by somebody. I'd be dead interested in Dr. Lewis's perception of all of this as our highest performing practice in the whole of Oldham. There's clearly some practices that match the reality to people's expectations. And I just think there's something about how do we get to a place with these 5 practices and making sure that reality does match expectation, because it clearly doesn't for some people. And I'm not entirely sure what the answer to that is just yet, but there's an improvement plan required in every single one of those practices that we need to be quite serious about, because it's not just about access to an appointment. There's other things in that survey where people are clearly unhappy about their individual practice. Do you want to comment about anything, Brian, before we bring Simon in?
Thank you for that. Thanks for the nice comments as well. It's really difficult. I think once your access is more challenged, it is very hard to get back on top of it. And I've been very fortunate at St Mary's because of our education and training. We've had significant numbers of junior doctors working with us as well. And we have a good size workforce to enable good care. I know that not everybody else can do that. And I think it's just a really challenging arena. We go the other extent, to be honest, because we get patients to be able to come in so easily. We often get demands of patients to come in twice in the same day. They want second and third opinions. So I think we sometimes have got to look what we're doing. I think we need appropriate access, but the extent of the ease of the access has got to be looked at. And I think across Oldham, it's extremely variable. And we have some practices where access is not necessarily so easy, but they get such a good experience when they come in that the patients are quite happy about the service there. And it really depends quite often on the demography of the practice as well. So there's numerous bits there. More than happy to work with the GP board on areas that we can actually look at with individual practices or right across the board, to be honest. But as I said earlier on about the education, I think it's really about making sure we've got a suitable workforce in place to enable things to happen as well.
Right. So I do agree with quite a lot of that, Brian. So I know Marion and I have certainly been in conversations earlier this year about one of those practices who've actually for a very long period of time been doing things over and above what they're contracted to do. But now there's been a big national change around certification of death, for example. The practice has moved back to what the guidance now says, rightly so, and now there's kind of quite a lot of outrage in the local community about they've changed and doing something different. They should never have been doing what they were doing in the first place. So there is something about expectation management and kind of getting everybody to the right level of understanding in loads of ways. And I do agree with your comments, Brian, about practice training, education. It's quite important stuff, this, to say the least. Thank you for that, Simon.
Sorry, yeah, a lot of the points I was going to make have been made by Brian and Andrew. Thanks for them. The practices have taken on board. They were devastated. The whole staff were devastated by some of the results, and it does have an effect on them. The amount of work that they have put in already towards improving these is quite evident. Some of the work that they've put in with their own surveys, the responses they've had back, it promotes a lot better picture. And you know, they'll have the support over the forthcoming months from us to improve that again. Some of it is around the education of the patients. There's different ways of accessing now because a lot of it was based around the access. So there's education going forward from the practices in different ways to try and promote that as well. So there is a lot of work going on. So just to make that emphasised.
Brilliant. So I think we need to find a way of making sure that we get that message out there to various different stakeholders that actually there are improvement plans in place and they're being worked through. I'm thinking particularly, Marion, some of the elected officials that you and I tend to have to deal with on a more frequent basis. Thank you, John.
And that's an interesting point, isn't it? That a lot of people who complain to us complain about other people's experience, because when we ask them directly what their experience is, they said, well, to be fair, my GP manages to see me within a day. So I think you're right that we must not just wave these figures away because the confounding factors are the same for everyone. We know that deprivation lowers your score by 10%, but then, you know, Brian will tell you he's in the middle of St. Mary's, which is a very low deprivation score, and yet he's one of the best. And so for me, not repeating what the people have said, I do think there's something we can do as a system about comms. So we are putting on 120% of the appointments that we did before COVID. But, you know, we talk about deficit model, but actually look at that sea of green in our CQC results. Look at the fact that the access, although it's bad, has improved, and the digital stuff is starting to finally move up a little bit, because that's where I think some of this access will be. So we will see some improvements next year because of the landing of the hours rules. So this survey was taken when we were about 30% to 50% of the hours rules in place, because they've taken a while and been difficult. And now those hours rules are you know, much more active. So we'll see the impact of that. But for me, yeah, and you'll remember, Chair, that just after COVID, we were tweeting quite a lot about the number of appointments we were putting on, how they were more. I remember going to the Health and Wellbeing Board and asking the entire room to estimate what the face-to-face ratio was, and the room came up with an average of 25%, when of course we're doing 75% of our encounters face-to-face in primary care, which actually I think all of us would have bitten our hands off 4 years ago for that ratio, because we did want to move 25% of general practice onto digital, onto video, onto telephone. So I think we probably have to repeat those messages in the press. And if I could say strategically, bearing in mind that the survey comes out sort of in February next year, it would be good maybe in the new year to have a couple of months where the system supports our local primary care by, you know, putting some stuff up about the alternatives to the 8 o'clock phone call, the you know, the raw numbers of appointments that are available, and also the blend of those numbers, And then just lastly, I think it's about supporting our GP. It's supporting the GP. It's about that reception triage. I know on a good day, I can sit in a GP practice and hear the receptionist say, "We haven't got anything today, but here are the 7 other options for you. You know, 111 PED services, etc., etc." And I think if every practice was doing that routinely, that would also change these numbers. Thank you.
Thanks, John. Brian.
I just want to add that there's something I think, as John said, about communication, but practices are really good at doing their own friends and family scores, etc., which mostly are very good. The survey just comes out to practices quite anonymously early on in the year. We all know they're coming out, and the first time practices tend to think about them is when the scores come out in July. We also know that the survey itself is not necessarily the shortest one to fill in, and that people who fill it in have often got a little bit of a gripe because they want to have a go back at their practice. Possibly we should be encouraging practices to recognise that there's a survey coming out between January and March, and encouraging practices to get their patients to fill those forms in. Hopefully we can increase the figures then, and hopefully as we increase those figures, we'll start getting the patients who are happier with the service actually filling in the forms as well. So possibly a little nudge from the ICB won't do any harm.
I agree with that, Brian. I think, so we've had a pretty good go of that report. Don't want to prolong it anymore. We know what we're doing with DRU. There's improvement plans in place for the survey stuff, but there's some things that we need to do as a system and not just rely on general practice to try and solve the problem themselves. So I think we can take that on board from here and move it forward. I'm conscious of time. I'm going to move us on a little bit, but I'm going to jump over the sit rep and pulse check stuff because that's a bit looking in the mirror. We'll come back to that. I want to talk about the incentive scheme update. Sorry, I've lost my agenda. Marion, is that which one? Who's doing the incentive scheme update, Marion? My apologies.
It's the lovely Gail.
Good. There you go. Thank you, Gail.
Thank you, Chair. So really just to go through some of the highlights of where we are in terms of the scheme for this year, which started in April, will run for 12 months until the end of March next year. So the aim of the scheme is to build on existing contractual arrangements for general practice with the ultimate aim of reducing health inequalities and improving outcomes for Oldham residents. As I just said, we're now halfway through the scheme, so midpoint. So just to sort of go through some of the key points and achievements that are noted in the report. Pleased to say that all Oldham practices qualified for the scheme and are now actively delivering it. The scheme itself was set up to be delivered in 2 phases. So the first phase was almost a preparation phase. Main focus for that really was focusing on frailty and making sure that post-pandemic that all practices were complying with the GP core contract requirements around frailty. So all patients, all residents over the age of 65 should be screened annually for frailty. This was a significant piece of work, I think it's fair to say, for all practices who have completed it. This involved screening for over 40,000 residents in Oldham. Pleased to say every patient in Oldham over 65 has now been screened for their individual degree of frailty. That piece of work in itself has identified 2,830 people who are now living with severe frailty, and 95% of those have received appropriate intervention that includes a structured medication review and a conversation with their practice about any falls, slips or trips that they may have had. That's as a minimum, with other appropriate interventions that are needed based on the individual patient's situation. Again, as well as identifying who those patients are and providing that intervention, it will benefit the wider system in terms of reducing any adverse health outcomes for our older population, but also hopefully having a positive impact in the number of a reduction in the number of people who have falls and ultimately end up in A&E or an unplanned hospital admission. All practices now have systems and processes in place to make sure that that process is reviewed at least on an annual basis, and they're all being encouraged to do that piece of work annually in preparation for winter. So I think definitely a positive impact on the work that all practices done, and just extend thanks to practices for the efforts that they've all put in getting that achievement. In terms of the shared care element, we've now got 1,500 patients on practice registers who are regularly being called for monitoring as part of their routine business, which was variable, and there was some degree of inequity across practices around that prior to the scheme. All practices are now providing that regular support and monitoring as part of routine business, which is really positive. And then the last element of the first phase was around prescribing, where practices were asked to start to work on the reduction of prescribing for items that are classed as drugs of limited clinical value, or items that were on the National Do Not Prescribe list. And these are drugs that are not, and treatments that are not routinely provided in primary care. There are some exceptions to these where patients are socially or financially vulnerable, and as a result of that, practices are not expected to reduce the prescribing of those items to zero. When we looked at the baseline position in terms of the prescribing element, the targets were unachievable in the short term, so all practices have been given a target that they have to achieve by the end of March next year. At the latest. Based on the latest results, so at the 30th of September, all practices are making really good progress in terms of the prescribing, and a third of practices are already at the Q4 target, and that position will need to be maintained. And then the sort of the last phase of the last element of phase 1 was asking practices to look at information and data to help with case finding, proactive case finding of people with diabetes, COPD, or children with asthma. I'm pleased to report, as a result of that, since April, 161 more patients have been diagnosed with COPD across Oldham, and 846 more people have been diagnosed with diabetes, which means that they will now start to receive proactive care and monitoring, which will ultimately reduce their mortality, and morbidity. Phase 2 of the scheme started in June. This will run till the end of March next year, and this is focusing on, again, proactive work around identification and management of people with diabetes, COPD, frailty, and children with asthma. So in terms of the prevention work, the practices have now identified an additional 1,351 people who've got non-diabetic hypoglycemia, and as a result they are at increased risk of developing type 2 diabetes. These are all now being offered appropriate lifestyle education and support to make lifestyle changes to reduce their risk of developing type 2 diabetes, and also including referral to the National Diabetes Prevention Programme, which is the recognised evidence-based lifestyle change programme for people at risk of type 2 diabetes. Overall now we've got almost 18,000 people who've got NDH, non-diabetic hypoglycemia, and are at risk of type 2 diabetes. These are now being reviewed at least annually by their GP practice, and as I've said, being provided with the appropriate and support to try and reverse that position. Practices as part of that are working to increase the number of referrals of patients to the NDPP and other weight management and lifestyle programmes. So far, the scheme's resulted in an additional over 2,000 patients being referred to the NDPP, with referrals increasing from 5,346 for the 2 years to March to 7,387, and that's the position at September, so quite a significant increase. The locality's work around this has been recognised we've been recognised as one of the best performing localities in GM, particularly for July and September, in respect to the number of patients being referred into the programme, and that's as a direct result of the scheme. Since March this year, an additional 303 patients have started the NGP programme. This includes the range of options that are available to patients, such as their face-to-face or remote online sessions. And then there's a digital option as well that's delivered via an app, and patients are supported with additional materials, things like cookbooks to help them. In terms of people with a confirmed diagnosis of diabetes, those who are have diabetes but are also overweight or obese are being encouraged to participate in appropriate weight management programmes. And referral of patients in this group again has increased significantly from 933 for the 12 months to March to 1,313. That's between April and September this year, which is an overall increase of 380 patients. In terms of the diabetes management, all patients should be offered an annual review, at least, to ensure that the 9 key processes that are recognised and advocated in national guidance, that patients are at least offered those. I think the position was, and it was partly post-pandemic, was variable, and there was inequity around that across all practices in Oldham. Position in terms of where we were starting from in April was highlighting that there was a reduction in the number of patients that were receiving foot assessment and renal screening in particular. So the aim of the scheme around this part of the diabetes element is to ensure that all patients are offered all 9 key care processes. An aspect of that is focusing on glycemic control. So we've got a number of patients who have the HbA1c, which is the measurement of the patient's glycemic profile, in high or very high categories. And we're asking practices to put some emphasis on those patients in an effort to review them and get their levels down. This is challenging for general practice, but already there's been a positive impact, albeit on a small number of patients, but this is expected to increase over the coming months as patients in these categories have their HbA1c reviewed every 2 to 3 months. And then the last aspect of diabetes is around retinal screening. And while it's generally accepted that practices don't directly provide screening for diabetic retinopathy, the regular view with and contact with patients does present an opportunity for practices to educate patients on the importance of screening. As a result of the scheme, the number of people with diabetes has also increased, and by default, the number of people that are eligible for retinopathy screening has increased, but both cohorts have seen an increase in the number of people now attending for retinal screening. And again, this is expected to increase further as the annual cycle of screening continues. Moving on to COPD. Again, this is about encouraging regular review of patients and ensuring that all patients that attend for their review receive care that's in line with national guidance. I think in terms of some aspects of this scheme, we have to recognise that some patients are not capable of carrying out some of the processes. So inhaler technique is a physical test, and some patients are not able to do that, or in some cases patients will decline, and the performance and monitoring of this aspect of the scheme takes those cohorts of patients into account. But overall, since March this year, the locality's seen a 5.8% increase in the number of people on COPD registers that have now got their severity of disease recorded, which is useful in terms of commissioning services to support them so that we know what cohorts will benefit from what intervention. And again, this is anticipated to increase significantly as we move through the rest of the year when patients are attending for their regular reviews. Asthma, this particular aspect of the scheme is prospective and focusing on children aged 6 and over, but under 19 years that have been diagnosed with asthma from April this year. So far, it is variable. The position with this is variable because it's dependent on a practice by practice in terms of the numbers of children that have had a diagnosis. The results for this are not as positive as some of the other areas. So the monthly monitoring of this aspect of the scheme is really useful for both ourselves as the commissioners, but also for practices, so that we can work together to identify which patients are not necessarily receiving the comprehensive package of care, and work with those practices to address that and help them to put remedial action plans in place where they're needed. But on a more positive note, the number of children on practice-based registers who have received a full review in the last 12 months has increased by over 21%, and that's at the September position. But again, and this is anticipated to increase significantly as we move through the next 6 months to the end of the scheme in March next year. And then the last focus for the scheme for this year is around frailty. So whilst we've got the GP contract that focuses on screening the over 65s and intervention for those with severe frailty, this aspect of the scheme is applying that same process and principle, but addressing the issue and providing intervention for those that are identified with moderate frailty, so that we identify those people early and get interventions in place as soon as we can. In the last 12 months, the percentage of people with a moderate degree of frailty that have had a medication review has increased by over 10%, and those that have had the discussion regarding falls with appropriate intervention has increased by over 9%. And again, with the rest of the scheme, because we're only midway through, this is expected to increase further as we move towards the end of the year. There is a smaller aspect of the scheme where we're looking to target and proactively intervene with patients who are at risk, increased risk of falls, but there's more work to do on that aspect of the scheme because the starting position has changed due to additional codes being introduced nationally that have affected our baseline. The team are continuing to work with general practice, particularly practice managers through the Practice Manager Forum, but all practices are being encouraged to contact the primary care team if they anticipate any issues or problems or queries in being able to deliver the scheme in full. And individual practice meetings are being offered where they're being requested. So in terms of next steps, the performance against the delivery of all aspects of the scheme are monitored monthly, and where there are potential issues, these are flagged with practices. And as I said before, if any remedial action is needed or additional support's needed, then that's being provided. I think it's fair to say overall the scheme has been very well received. The period between April and June was in terms of the ask for practices was significant, and I think we need to extend our thanks to all practices in Oldham for the amount of effort that they've put into getting us to where we are at this point in time. Also want to acknowledge the input and support from BI and data quality colleagues whose support has been excellent and continues to be excellent in developing and supporting the scheme. In terms of where we are, I think we are in a very good, strong position. I think we've got the next 6 months that we can really build on the progress that we've made so far. But beyond that, it's awaiting clarification of what our options are in terms of a quality scheme moving forward from March 2024. Thank you very much.
Thank you very much, Gail. John.
Thank you, Gail. Thank you, Chair. Apologies for jumping in first, but I'm going to have to go back, obviously, to this really exciting conference. We all remember, or many of us remember, several years ago, we had an incentive scheme that we instinctively knew was the right thing. We thought was in the right ballpark area, asking for the right behaviour changes and the right work, but we had no evidence. And it was very hard to find the evidence. And yet, Gail, you probably could, you could have spoke for another 10 minutes about the stuff. So, that was a long segment, but that is what the scheme is doing for the providers and the population of Oldham. And, we have this half-day clothing that we say by benchmark is a bit more accommodating than the rest of GM, but from the same pot of public money, we also have this scheme, which I would argue is a bit more stringent than the rest of GM, and that feels like a nice balance. The scheme also feels durable because, well, it's obviously durable because of the outcomes that you've described, and I think we'll always struggle for a return of investment description, but we're in a better place now than we were, because even in the work that I've done in my own clinical practice, doing the frailty, doing the medication, doing the shared care, you do find the odd case where someone would have fallen through a couple of Swiss cheese holes to end up in hospital, and probably 5 or 6 patients in hospital who are diverted cover the investment in this scheme, because general practice is so incredibly cost effective as an intervention for the whole health system. So I really thank you for your work, Gail, and thank all our colleagues in primary care. And this is exciting because, I just want us to note that balance of the scheme, a stringent scheme, but actually a permissive education program, and they are the same pot of money. The second thing, though, is in Oldham, we are really good at moving forward, even with disagreement. And so we are a mature leadership, and so we can disagree but still move forward. And I want to acknowledge, the role of our GP leaders who have allowed this scheme to move forward. I'm really grateful that they actually populated the workshop. So we had a really useful workshop at the very start of the scheme where significant managers and clinicians and some nurses turned up from the PCNs and really helped sharpen the focus of the scheme. And I think that's increased the ownership and that's increased the outcomes. I would hope that we can build on that relationship. And so, Brian, we have the GP board, haven't we, who I think should have full sight of these figures, but also in terms of next year, I think, so we definitely, I wouldn't say we definitely have this investment from the ICB. I wouldn't say we possibly have it. I think we probably are going to have this investment. I wouldn't say we have a new scheme. I probably wouldn't say we probably will have a new scheme. The possibility is that we will have one more year of our own scheme. Now, they are punts, and we do need to work hard behind the scenes because general practice needs this investment. But in that scenario, it would be good for us, now we have more time and less reorganisation happening around us, to make sure that the next iteration builds on this and absolutely feeds in all the expertise that we have from our GP leadership, the lessons that we learn. I think we have to have I personally, and it's not an ICB view, this, I think we just have to look a little bit of some of the thresholds for 3 of probably all of the indicators, just to see how they run and what's possible. We've always had a history of doing that, and as this data builds, let's organise another workshop and do that. And then lastly, I do think that this is, I'm sitting here today for elective care in a second, but what we're doing in Oldham does impact the entire global spend, and so this is the committee that votes and passes these schemes, and so I would commend it to you and commend these type of schemes in Oldham, because I do think the whole system has a financial win. But I think about those individual Oldhamers who now know they've got diabetes, who now have been referred to NDPP, who now have had their frailty identified, who now have had their asthma inhaler technique reviewed. And it just makes me sleep a bit better. And we will see a shift in the patients in Oldham who have had all 9 or 8+1 steps of personalised care and diabetes. And so, we should really mark what's happened. And I suppose that was the last point, that it took a little, because general practice is so busy, it took quite a bit of a push to get us to this 3-month stage. I've been interested, from Brian and Andrew and from others, how do we keep this behaviour going? How do we keep this going? How do we keep the focus on, landing the frailty and the diabetes and everything else? Because there is a chance that this will pause now until we get the next QOF push, and I'm just worried that might not be, might not allow us to take as much of the value from this scheme as we want. So that's my, that's a question at the end. But thank you, Gail. Thank you, everyone. And I get that there was a messy birth for the scheme because of the reorganisation. But my goodness me, isn't it amazing that we can sit here and point to the good stuff that has happened already? Thank you.
Absolutely endorse those comments, John. I definitely don't want us to spend as much time in the preparation of next year as we have done for this year. but it's very important that it's an engaged process. I don't think anyone would disagree with all of that stuff. So, Brian, is there anything you want to come back with to that challenge?
No, I think we really want to engage from the GP board and be involved from the start of any plans for a scheme. I'm certainly working with GM on whatever incentive or quality scheme that they're looking for in the future, but I assume that's going to be not till 25 now. So assuming that happens, we do need to make sure something happens in Oldham from April 24. I would love to see continuity of a scheme that we're doing now on the basis that there's too many chops and changes quite often. So looking at a continuing scheme with further development, but links with the GP board would be absolutely ideal. Thank you.
Okay, well, I think that's a firm action that needs to come out today, Brian. So I think we're quite happy to state that. So report great signs. I have absolutely no doubt in my mind. Without this, we'd have been seeing increased activity through the front door of the hospital right now. So, you know, this is yet again another testament to how primary care steps up, identifies patients that are potentially at risk or likely to be at risk, and puts interventions in place to manage their condition before it gets too late. I mean, that's the fundamental part of this scheme in a nutshell. We need to move forward on the next iteration of this in a much more engaged way, notwithstanding the issues that we had at the start with changeover and all the rest of it, which I won't bore everybody with. So thanks for the update, Gail. I'm going to, while we're on the roll with Gail, let's do a very quick look-see over the diabetes thing, and then we'll come back to Sam for the sit rep. Probably a very quick version of this paper though, Gail, because it is quite straightforward. Thank you.
Yeah, it's as members will note from the report, this is just again an interim update on work that's been done by 2 diabetes educator associates within general practice in Oldham. Again, it's just for information, but just to sort of in a nutshell really go through the key points from the report. The locality did receive some non-recurrent funding from the Greater Manchester Diabetes Board in 2022, and the focus for that investment was post-pandemic recovery for people with diabetes and restoring care to pre-pandemic levels, and particularly focusing on identification and routine monitoring for people with diabetes. The funding was used to recruit 2 whole-time equivalent Band 4s. Recruitment was challenging given the specific nature of the post and the people that are out there in the system with the appropriate knowledge and skills. Ultimately, we had successful recruitment to 1 post in April of this year, and that person is now employed by Oldham Diabetes Service, where they receive their clinical advice and supervision as part of their own sort of personal role. All practices in Oldham will have the opportunity to benefit from the work that the education associates are doing, and the focus of the work is going to be working with all general practice but through their respective PCNs, and prioritisation of the work that they're doing with each PCN has been based on the diabetes prevalence in each PCN and the demographic of the registered population. So those that are increased risk will be prioritised first. So work started with Central PCN earlier on this year. Feedback from the practices has been extremely positive, and I'm sure Dr. Lewis would want to comment on some of the work and experience from his member practices. Lots of learning and outcomes from Central PCN in particular, which are highlighted in the report. Work is continuing with Central on some of the work that they've already started, but some of the opportunities as well that's been identified directly through the work that the education associates have done. More recently, the education associate has moved to South PCN. The second post holder has now been successfully recruited to, so they've got two post holders now that are working with South PCN. the work in that, the approach in South is a little bit different to the work that was done in Central. So they're using the skills and expertise of the diabetes education associates to work as part of the wider PCM diabetes team that includes diabetes care coordinators, the generic care coordinators and social care prescribing coordinators, with a focus on training and education of all staff and patients. So overall, so far, I think very positive piece of work, being well received by general practice and the wider system. We've asked for interim reports from PCN leads on the work as it progresses and prospectively going across Oldham, and we can bring updates back to committee as and when we get them. There is a risk with this work that the 2 posts are funded non-recurrently, and so beyond July 2024, when the funding for the second post holder finishes, but it's the legacy again. It's like the scheme, it's the legacy of how we continue to provide that level of support and input, particularly to general practice, and how we maintain that going forward if those posts are not maintained beyond July next year. That's where we are currently in terms of the progress that we've made so far, and we can bring interim reports back if that's what the committee prefers, or a final outcome report towards the end of next year. Thank you.
Thanks, Gail. So I think it would be good to bring another report back before year end, just to see progress. I also think that report probably needs to be timed in such a way that assumes the thing stops. That way we have a proper debate about if it was to stop, what do we do? What we can't do is have that conversation like 2 weeks before the thing is supposed to come to an end. So if we can structure the next report to come in such a way that it allows for a wind down of the service, then we've got enough time to have a discussion about what we do, either continuing or not continuing. So that would be really helpful. Great report though. Brian, is there anything you want to say about
I just want to say
you're the PCN lead?
Yeah, it was very positive. I think the only thing that happened really was that it was a little bit of a shock to the system to actually have the educator in place in the first place, because it came via the NCA, I think, rather than directly into primary care. So there was a bit of a surprise there, but I think overall it's been very successful. I think there's various bits that need to happen as a result, including looking at the whole of the community diabetes service and what's available, especially with the increasing prevalence of diabetes, as Gail has already said, but also the nature of the population, especially in Central, and the need for various different languages, etc. The community diabetes service is quite challenged at the present time, so I would encourage commissioners to be looking at what can be done to enable increased workforce within the Oldham area. And I'll leave it at that.
Brilliant, thanks very much. Okay, so the report's here to note, and I think we should note it with a lot of good intent, Gail. Some brilliant progress made as a consequence of all of that, which brings us then to the last formal report in this part of the agenda, and Simon on the SITREP.
Thanks, Chair. I'll keep it quick. So the SITREP has been asked to reintroduce the SITREP throughout Oldham. I will add that it's been around for a while. Oldham didn't report back to the GM SITREP, so the data was quite old that we were looking at, but there was a locality, an Oldham locality SITREP going on during that time, which was a little bit more detailed, but they're asking us now to report back into GM. So the SITREP is basically there just to try and prevent any build-up or any unexpected demand. It's a very simple form. I think there's 3 questions initially around increased patient demand, any staff shortages, or any IT or any increased access demand. And then along with the SITREP, there's also the pulse check, which is a rated 1 through to 10, 1 to 4 being no increase, very little appointments going on, and then 5 being business as usual, 6 being small increased demand, 7 and 8 being significant or very significant, and then 9 and 10 being critical risk, basically. Currently across Oldham, we've not had any 9 or 10s, we've had a couple of 8s. Majority, and I think I put in the report, I can't remember off the top of my head. So I think there's currently, last time we checked, there's about 61% of practices reporting a slight increase, but nothing that they're not coping with. And there's the last week we checked, there was 3% of practices reporting an 8. Every practice that reports a 7 or 8, I've been getting in touch with just to see if there's any support that we can offer. And it's basically just that they are busy, they are coping, they've got things in place. It's just that they have seen a little bit of an increase. The SIREP's there hopefully to try and prevent, improve patient care, ultimately. Early detection of things that are going on, winter issues, winter access issues, hopefully optimize the workforce. I'm just going to read through some of the things. Prevent some of the burnout, so looking after the staff. A lot of the staff have said that in previous years they've really struggled, so we're hopefully trying to look after the staff there. And this is about reallocation of resources across Oldham, hopefully, if possible. Hopefully utilising some of the PCNs, if we can utilise the PCNs in some ways to support the practices. Most of the practices have reported that it's fine to use. It takes about 30 seconds. There's no issues with it. It's quite quick. We have had to chase a couple of practices up. Hopefully we have seen an improvement over the first few weeks. So hopefully that will continue.
Okay, thanks. Thank you, Sam. So yeah, I'm wondering if this is something that you would welcome as a regular report to the GP board, Brian. Gives you a bit more visibility of kind of a rising level of concern or a rising level of pressure in primary care, which I think could give you an opportunity in the PCN networks to either do something as well as what we're doing. That doesn't preclude the conversations that we have anyway, but if that's something you want, then we can make that happen for you.
That'd be great if we could. Yeah, that'd be lovely. Thank you.
Brilliant. Marion.
I just want to reflect back to the committee and give some examples of the support that's been recently offered to practices, because I think what we don't want here is form filling for filling's sake. If a practice reports that they are under pressure, what I want to stress to the committee is that there is a follow-up conversation with them, and we do try and access appropriate support to meet their needs. And some recent examples have been through Celeste and Simon helping practices with community engagement, community conversations, PPGs with their registered list. Through the GM team, we've organised some HR support and advice for a practice that needed it. For another practice, we organised a financial health check through the GM team to help them with some cash flow issues that they were experiencing. So, there's not a blank checkbook, but there are, support mechanisms in place that practices can access through flagging through this form and then through the quality of the follow-up conversation. So it isn't a meaningless exercise. It is a way to access a package of support. Thank you.
Very helpful point of clarity, Marion. Any other questions on this? No? Brilliant. That brings us, I believe, to any other business. Has anybody got anything else? In which case, thank you very much. I'll drag the meeting to, oh, there's one thing actually, my apologies. Nick.
I'll just dive in at the end there. I just wanted to acknowledge that the local operator committee had its AGM earlier this week. Our chair in his report commented on the fact that we were now being invited to PCCC meetings, not just in this area, but elsewhere in GM. And that was welcomed. So although I may not have a great deal to contribute, it's been a pleasure to be involved. You all seem very nice, and I may not fully understand all the ins and outs of what you do, but it's interesting to see what work goes on. So thank you.
Thanks, Nick. I'll take the all. We all seem nice. We haven't bitten anybody today, so that's always a good sign.
Anything too terrifying.
And as as we get through this agenda and the development of devolved powers down into places, it'll become a little bit clearer about all the different professionals that around the table. So, you know, you might not feel like you've got an awful lot to say today, but I think that's going to change as things go forward. The one bit I did miss at the start was the action log. My apologies for that. I'm not going to let us off with that. There are some things that we just need to sort out on here. So the first one on the barriers and refugees phase, I think that's complete now, isn't it, Marion? I don't think there's anything left with that to do.
Yes, it's complete, Chair.
So that's done, so we can confirm that that's done. The block lane surgery allocation review PCN stuff, that was on me, that action, and sadly I spent a month in hospital pretty much, or out of action for a month, so I'm just going to defer that to the next meeting. I do have a report, just needs to be looked at, and I think Marion, myself and Tarek are meeting on Monday to finalise that. I couldn't get it done before today, so you just have to bear with me on that one, with apologies. The workforce, I believe, is absolutely closed down now, and the review of PPGs is also been closed down now, unless Marion's going to tell me there's been some issues with meeting some more.
No, and I think this is becoming now business as usual, and Simon, through his conversations with practices supported by Gail and Tarek, will pick those conversations up now through routine assurance visits and get practices support as needed.
Fabulous, thank you. And on the very last one, which is kind of a rather technical thing about the governance side of it, we've made a number of changes to this meeting under request of the ICB itself. So now every single part of Greater Manchester, or every single one of the place in GM, has the same terms of reference and the same approach to this meeting. So that's all covered off, and we just need to complete the interface with Ben Squires from the ICB point of view, whether he needs to be in this meeting or not. And if it's not him, who is it, and does it need to be anybody? But that will be done over the next couple of days, no big deal with that. And that concludes the meeting. So thank you very much. Have a jolly good day. Enjoy your weekend when you get there. And there's a number of us that have got another meeting now. Should we meet at 11 o'clock as planned? Give everyone a chance to get a quick cup of tea. Thank you. Cheers. Bye.
Thank
Thank you. Bye.